Good morning to all who have tuned in this morning to the second last Grand Rounds lecture of the year. As you all know, this is sponsored by the Jean Shanks Foundation and it's a collaboration with the Pathological Society. It gives me a great pleasure and an extreme honor to introduce you this morning to Professor Peter Schirmacher, who will be giving us a presentation about hepatobiliary carcinogenesis. Just a brief background to Peter. He's the current director of pathology at Heidelberg University Hospital in Germany. He's also the director of the Center for Personalized Medicine there. He's currently the president of the European Society of Pathology and has had this role for the last 2 years. Previously, he's been president of the German Society of Pathology, and he has a very impressive track record in academic pathology and pathology research, having published over 850 documents and has, again, a very impressive H-index via Scopus of 102. He's been very much involved not only in such research papers, but also in textbooks and key textbooks such as the WHO, tumor volumes, and also guidelines. So thank you very much, Peter, for sparing your time this morning and to give us an update on hepatobiliary carcinogenesis. The floor is yours. And just to remind everybody, please use the Q&A function where you can write questions, and we'll go through as many as possible towards the end of Peter's lecture. Thank you very much, Peter.
Thank you very much, Sarah, for this kind introduction. It's a great pleasure to be with you in the next 45 minutes or so and to tell you some of the work we have done in hepatobiliary carcinogenesis and how it crossfeeds with diagnostic pathology and how we also extract new input from diagnostic pathology back to research, and this especially in hepatobiliary carcinogenesis. I can't move it now.
If you just left click on it.
Left click. Okay. Okay. So yeah, what I'm going to talk about is how this relates to morphomolecular subtyping in our entities, how we use these findings to define malignancy and define specific entities, how molecular pathology contributes to that, and how on the other side this need drives molecular pathology and also the way we interact with our clinicians and how we work in personalized medicine. Just a few words about liver cancer, specifically hepatocellular carcinoma. It is one of the most frequent entities. We're always fighting if it's number 3 or 4 in the world, and it still shows a rising incidence despite a lot of measures we are taking, and we still are not perfect in our therapeutic options. It has improved over the last 10 years, as you will see, and we still do not have predictive diagnostics in place to guide our therapy or systemic therapy. Thus, prognosis is still meager. Incidence more or less equals mortality. But on the other side, it's a very rewarding model, as I've seen over the last 3 to 4 decades. It is the paradigm of viral metabolic and inflammatory carcinogenesis, more than any others, and it is the disease where we have the best tumor models to study in animals. Just if you go back to pathology as it was 3-4 decades ago, this was the thing we were looking at when we looked at hepatocellular carcinoma. We looked at the macroscopic pattern, at the histological pattern. These different patterns have been worked out, the nodular, the massive, the diffuse type, multifocal growth, and of course the different histological pattern we're seeing. Although some of them are actually of interest for our interaction to radiologists. For example, the diffuse type is certainly underestimated when it's in the radiologist's hands, and we have even seen transplanted specimens of this type of disease where the tumor load has been, actually underestimated. But it doesn't matter on prognosis and on specific therapy. If we go one level down, we have the cytological changes, which are typically found in hepatocellular carcinoma, such as Mallory hyaline. We can see fat in the tumor cells, pale bodies, which are probably due to fibrinogen. We can see other inclusions like alpha-1 antitrypsin, and we have cytological cytoplasmic changes like oncocytic change. They also do not largely do not matter on prognosis. They support diagnosis, especially if you have actually metastatic sites. And so it is important for our diagnosis, but it does not change the prognosis or the way we therapy it. So the next step, the next level, actually, we're looking at, and this is work from the group of Jessica Zuckman-Rossi in Paris, was can we actually more or less subtype HCC just by using the molecular alterations we're finding? And there has been some progress, and it has been used to subgroup HCC, but it hasn't made its way to clinical diagnostics, mainly for a couple of reasons. It is still not clear if this subtyping is actually typing or if it's staging. And there's, as you can see on the diagram, a lot of overlap between the different groups. So it's not a clear distinction. And it is not clear whether there's a certain hierarchy of the pattern. And as these data have been obtained in resection specimen, it only attributes to stage 1 and 2 HCCs, and we do not know very well how this pattern looks like actually in progressed HCC. And what we have learned is that some of the specific molecular morphological pattern we have found in hepatocellular carcinoma are actually missing in these constellation. And the eye-opener and really a game changer was the finding, which was driven by Mark Torbesen. We were happy to contribute to that, and also by others like Sandy Simon at Rockefeller's, who did the molecular analysis, is the finding on a specific subtype of HCC, which is fibrolamellar HCC. It could be shown that this subtype is due or on the molecular level reflected by a singular translocation, the DNA JB1-BRCA8 translocation. So you can more or less say in 99% of these tumors, if you don't have the translocation and you have a hepatocellular tumor, it is not fibrolamellar. You need this translocation to actually be sure that it is, or you need the specific histopathology, which is always the same. It's the same in the primary tumor and the metastasis at the beginning of the tumor or at the late stage tumors. So it is the same from the cradle to the grave. And this shows a specific correlation of the morphological type and the molecular alteration. And there was more, which we found in the later course. There is a rare subtype which is called chromophobe HCC, sometimes called chromophobe HCC with abrupt anaplasia, because the tumor on one hand shows the chromophobe cytomorphology, as you see on the left side, but then there are areas of the tumor show brisk nuclear atypia, anaplasia, and other areas show these small pseudocysts within the tumor. And this tumor is correlating with the alternative lengthening of telomeres phenotype. It's not a totally one-to-one correlation, but all these tumors show these phenotype. And this subtype of HCC, the frequency differs between the different studies between, let's say, 2 to 5%. There's more. There's serous HCC, which has a remarkable stroma, but not a fibrolamellar stroma, but has no capsule. And it has been linked, it's not so clear anymore, but it has been primarily linked to tuberous sclerosis and also to mutations in the TSC1 and TSC2 gene. We're not clear at the moment if this is truly the case in all these cases, and there's TSC mutation outside this entity, but there seems to be some kind of correlation. This subentity is very important because the radiologists typically confuse it with cholangiocarcinoma. Another subtype, which has been worked out by the group in Paris, published by Julian Calderaro, is the macrotrabecular massive HCC. Currently, the definition is that 50% of the tumor should be macrotrabecular, more than 6 or even more than 10 layers of tumor cells thick. And this tumor type has actually typically high AFP, sometimes over 100,000, and has a very poor prognosis, is typically in younger patients, always show vascular invasion when it's diagnosed, and is frequently correlating with amplifications of FGF19, thus actually correlating with activation of the FGFR signaling pathway. There's granulocyte-rich HCC, where the tumor shows remarkable inflammation and infiltration by granulocytes. The patients show inflammatory syndrome, which is actually leveled off when the tumor is taken off. And that's due to production of granulocyte colony stimulating factor by the tumor cells, actually. There's lymphocyte HCC. That is sometimes a partly differentiation, more rarely a differentiation, homogeneous differentiation of the tumor at all, where actually the lymphocytes infiltrating the tumor are outnumbering the tumor cells by far. And in contrast to other sites, here probably Epstein-Barr virus infection or positivity is rarely the case and has only been documented in one case. Of course, the differential diagnosis in this case is hepatic or occupation of the liver by lymphoma, and you have always carefully look for that. Another subentity, which may not, or in many cases does not relate to steatotic changes in the surrounding non-tumorous liver, is steatohepatitic HCC. If you look at it cytologically, as you can see here, there is a remarkable similarity to steatohepatitis, and due to the high differentiation, it's sometimes very difficult to distinguish it from steatohepatitis. You really have to look out, have to find other markers of malignancy, either immunohistochemically or, as you can see here, disruption of the trabecular network to really be sure that you have HCC. It is usually connected with activated IL-6 signaling pathway, and you also find the typical histological signs as you have in steatohepatitis: ballooning, fatty change, satellitosis, Mallory-Denk bodies. They can all be present in the tumor. And last specific type is clear cell HCC. You know it in its differential diagnosis to clear cell renal cell carcinoma, and that is the differential diagnosis. But these tumors are typically positive for markers of hepatocellular differentiation like OCH1E5 or arginase 1, or some areas of the tumor may contain non-clear cell parts and therefore might be easy to actually diagnose then HCC. But you have to know this pattern, and we in order to differentiate. Taking this all together, and that has been put forward also in the 5th edition of the WHO, we have now, I think, 8 different specific morphomolecular subtypes with more or less clear evidence. You see some red areas where we still have to do some work to actually substantiate it more, but it shows that a significant part of HCC, let's say 20 to 30%, are these distinct HCC subtypes. And of course, the further work is also due to maybe extract further specific subtype out of the large group of NOS HCCs. And to have some take-home message from that for general tumor research, what we have learned from that is that we actually have 2 different patterns of our cancers. There is, in different frequencies, depending on the site, the vast majority of those tumors where we have exogenous carcinogenic agents which are acquired, where there's multifactorial progressive tumor development, they have plasticity and develop therapy resistance. And there is a smaller, depending on the entity at site, it is more or less all of the pediatric and many of the brain tumors, for example, where we have these what we call bad luck tumors, which have oncogene addiction, one driving event, morphomolecular correlation, frequently connection to hereditary tumorigenesis, a homogeneous morphology, and a whole bunch of flowers of these different entities. And we have to look, and it only can be done by the pathologist and the molecular pathologist to nail it down and to find these specific subentities. So what we've learned is that liver cancer is actually an ideal model. Interestingly, specifically liver has mechanisms to more or less completely resist to hereditary cancer syndromes. They do not play a role in liver cancer. We have these two different groups of malignancy, as we can see, and this can be probably more or less extrapolated to other conventional cancers and can only be discovered when morphological and molecular expertise is paired, and this is a vast area for pathologists. How can we use these findings we have in liver cancer actually to tackle the next question, the definition of malignancy? Probably many of you have experienced that highly differentiated liver tumors, hepatocellular tumors, is a tremendously difficult actually task to solve out, where you have to the differential diagnosis of highly differentiated HCC, the precursor lesions of dysplastic nodules, hepatocellular adenoma, focal nodular hyperplasia, or even regenerative nodule in chronic liver disease. And cytological changes might be minute and might even be misleading. There have been a lot of work, excuse me, that has been largely driven by our Japanese colleagues, which has nailed down criteria using morphology, immunohistochemistry, macroscopy to actually delineate these different patterns to make diagnosis more reliable by morphology and to describe the carcinogenic process in HCC. What we know is that conventional HCC, not talking about these specific subtypes, more or less NOS HCC, develops out of premalignant lesions. First of all, dysplastic foci and then dysplastic nodule, and goes over to vaguely nodular HCC, which is probably still a kind of a pre-invasive malignancy, which does not form a capsule and probably does not lead to intrahepatic or extrahepatic metastasization. It's not a question of size. We can have capsule-forming definite HCCs at a size of 1 centimeter, able to actually spread in the liver and even extrahepatically. So we have to look at these discrete signs in order to make the diagnosis. Helpful in this context is also the whole clinical and disease context. HCC is much more frequent in males than females. Of course, predisposing diseases, which account actually for 80 to 90% of the HCCs we are facing, like chronic HBV and HCV infection, but chronic alcohol abuse, hemochromatosis, metabolic liver disease, they are, of course, increasing the probability of HCC. And if you find these changes in the surrounding liver, this is the same. So the matrix diagnosis is sometimes helpful to actually push the diagnosis towards dysplastic nodule or HCC. Then there are more specifically immunohistochemical and molecular tools to do that. We can look for the vascularization. Most, but not all HCCs have complete vascularization, as you can see on the left side. But the sensitivity and the specificity of this tool is not very high. We're using it, we're happy if you find it, but if you don't find it, it does not exclude HCC. Another finding that has been worked out by the group of Beth Brunt in St. Louis is that the encapsulation in cirrhotic liver can actually be diagnosed with the help of a K7 immunohistochemistry, because true encapsulation does not contain ductular proliferation, in contrast to a cirrhotic liver. So if you don't find that, that is a clear indication that you're looking at a capsule and not a cirrhotic septum, and that actually supports the diagnosis of already a progressed HCC. Another finding was that by the group of Luca Di Tommaso, who actually worked with a triple immunohistochemistry marker, which is the use of glutamine synthetase, heat shock protein 70, and glypican 3. And these turns out to be quite helpful. The sensitivity for HCC for malignant transformation is about 70% if 2 of the 3 markers are actually positive. So we're using that because the specificity of 100%, almost 100%, there's never 100%, of course, in medicine, but close to 100% is very helpful in this context. So we're using that. Also, the group of Jessica Zuckman-Rossi has looked at the molecular alterations throughout the development over the dysplastic nodules to HCC of the different molecular alterations. And the most frequent alteration is TERT promoter mutation. It's not easy to find. You can't find it with some of the conventional assays. It's in a GC-rich region. But as you can see here, the frequency turns up very much, up to about 60% in progressed HCC. So if you find it, it is also helpful to push you more on the side of either high-grade dysplastic nodule or progressed HCC, which actually is an indication for a resection or is helpful for the transplant indication. So what we know, and supported by these molecular alterations and immunohistochemistry findings, that we have this conventional way of HCC development, which goes from the dysplastic focus to dysplastic nodules to early HCC, maybe even early go to progressed HCC, actually stepping over these steps, and then to advanced HCC. And our aim is, of course, to define these early lesions, to make a clear diagnosis, to distinguish it from the benign counterparts in order to make resection or transplantation for the patients positive in a curative intent. So what we've learned from that is actually that the definition of malignancy in these highly differentiated tumors is really difficult. It requires a lot of experience, but also adjunct technologies up to even molecular pathologists and understanding to the molecular tumorigenesis. It is a continuous process, and there's certainly a gray zone where we have something like still not independent malignancy. We know that also from other entities like malt lymphoma, we know it from CLL, we know it from small papillary thyroid carcinoma, where probably the already malignantly termed tumor is still depending for an environmental signal, and if they can be interrupted or if they're taken off, the tumor might actually regress. We have seen cases of that also in these progression stages of hepatocarcinogenesis. So what can we learn from all these findings for definition of an entity? And to show you that, I will jump to an entity, hepatocellular adenoma, which is in the differential diagnosis and can also be a precursor lesion for highly differentiated HCC. When we go back ages, this was what I actually learned in hepatocellular adenoma. It's a benign tumor in females taking the contraceptive pill in a non-disturbed liver, and it is benign, and you can resect it, or you can maybe take off the hormonal treatment, and the tumor might actually disappear. It can rupture, and that was the story we were actually talking about. It has been the achievement of the French group around Paulette Biolaxage and others to show that actually adenoma is not one monotonous entity. It is actually can be subtyped in different sub-entities, as you can see here, HNF1 alpha deficient adenoma, inflammatory adenoma, beta-catenin activated adenoma, and just recently the sonic hedgehog adenoma. And there's only 5 to 10% of adenomas left that can be termed unclassified. And interestingly, these different subtypes show different clinical pattern, different immunohistochemistry, and even different molecular changes. Just to make you familiar with that, for example, inflammatory adenoma is an adenoma that shows on the morphology sinusoidal dilatation, inflammatory foci, and even portal tract-like structures, which was the reason that we termed it ages before actually a subtype of focal nodular hyperplasia. And then we recognize it's a clonal lesion and not a proliferative non-clonal lesion, and that this is due to alterations, molecular changes in factors of the IL-6 signaling pathway. And due to that fact, you can nicely delineate this tumor by doing serum amyloid A or CRP immunohistochemistry. Beta-catenin activated HCC is a different subentity where you can actually see activation of the Wnt signaling pathway as shown by activation of glutamine synthetase, and even in some of the tumor cell nuclei, you see nuclear accumulation of beta-catenin. But what you see here is there is some nuclear atypia. And that what we've learned, and the initial publication was in almost 40% of the tumors, is that they can transform malignantly. And they're an equal frequency in male. And these males typically show abuse of steroid substances, testosterones, anabolic steroids, and that in the further course, it could be shown that this leads to molecular alterations in the beta-catenin gene. And more interestingly, the extent of activation of the Wnt signaling and the extent of malignant transformation depended on the type of mutation. Exon 3 mutations, conventional, have a high transformation risk. Exon 7, 8 mutations less activate the Wnt signaling and have less malignant transformation. So we're looking at that. This is work from Jessica Zuckman-Rossi, and there was also a transition from that from these adenomas of beta-catenin activated type to HCC, accompanied by increase again in TERT promoter activation and then finally acquisition of other mutations. So the same story we have seen in conventional hepatocarcinogenesis. And just recently, we have found a very, very rare entity, which is hepatocellular adenoma occurring in familial adenomatosis polyposis. Those disease where we have germline inactivation of one allele of the APC gene. We have identified it in looking at all of our FAP patients at liver lesions, as you see here, and we finally found 3 lesions. So it's very, very rare. But what is the interesting thing is, it is a breakthrough lesion. It is one of the very, 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 very few tumors. It's not leading to malignancy, only to benign adenomas, where we have a hereditary tumor syndrome leading to liver tumor. So we could show that in these tumors, the second allele is lost, and there's a somatic loss of that. And there's further studies we have done now, which are still not published, where we could show that for more than 20 of these tumors we have accumulated. So this is a consistent pattern. So when we look through that, hepatocellular adenoma is not a monolithic entity anymore. It is actually has different subtypes, and these subtypes are so different in their behavior that we actually should not call, we still do it, but we should not call them all hepatocellular adenoma, because they fulfill the criteria of different entities according to the WHO. We have variable morphology, we have different molecular makeup, we have different etiology, we have different clinical contexts and different pathogenesis. There are adenomas which are hereditarily genetically predisposed, as you have just learned. There are adenomas where we have exogenous, acquired risk factors, like in metabolic syndrome, where we actually get HNF1 deficient adenoma. We have actually steroid abuse leading to beta-catenin activated adenoma. And we have also, of course, other factors. I'm just trying to move my slides.
I think the focus came off, so you just need to left click on the PowerPoint again.
Okay, there is a difference. There are adenomas that have oncogene activation, like we see in beta-catenin, in inflammatory adenoma. That's also the case in sonic hedgehog adenoma, and where we have tumor suppressor gene inactivation. And therefore, we have lumped in one disease together truly benign lesions with probably a low malignant potential, and where adenoma is only a transitional stage from a benign disease to development of HCC. So the lessons we've learned is we have to truly look into these different entities because it matters. It matters on the treatment, whether you have to resect it, whether you might just take off the exogenous stimulus, or whether you have to look for this disease in patients with hereditary tumor disease. And it opens up the way for thinking for new tumorigenic principles like incomplete tumor suppressors or new tumor syndromes like in HNF1 alpha deficiency. Another thing that is important is that we have drawn from this work is that pathologists need to get involved in the interdisciplinary interaction in order to put their different findings forward. And the key example for us was the role of liver biopsy in HCC. We need that actually in order to translate these findings to the human diagnosis and also to have these findings also taken back to research. And as you may know, is liver biopsy is not mandatory according to clinical guidelines to do HCC diagnosis if the patient has a cirrhosis and the radiological signs are typical, which are not specific for HCC. But this has led to many cases of suboptimal diagnosis and mistreatment option because of confusion with intrahepatic cholangiocarcinoma. It has set back the research in this field probably for 2 decades, I have to say. And a lot of expertise in diagnosing HCC and liver disease has been actually lost. This is the current guideline for treatment in progressed HCC, which cannot be curatively treated by resection or transplantation. And you see it's more or less a mess. There's a conflicting first-line treatment options, and these different treatments have been implemented without the use of biomarkers to assess actually for patients who are responding to this therapy or not responding, and to assess which of the treatments might be better. And that this is needed, this is just an example from the checkpoint inhibitor trials, is the fact that actually we treat 1/3 of the patients better at the expense of 2/3 of the patients which do not have any benefit or might have even a disadvantage constellation because we lose them quite early or the progress is quite early. And our community analysis have shown that only 60% of the first line progressors can be put in second line. So these patients cannot simply be put on a second line. They are lost. So there is the necessity actually to test for these markers. And there are good options. This is from the laboratory of Michiya Sakamoto. He can actually delineate with his marker attempts for those tumors that are immunologically hot and therefore more likely to respond to checkpoint inhibition. And we have done work with Bertram Bankshire, for example, just recently published, where we could actually delineate by extensive spatial analysis that the local compartment, the micromilieu of the tumor, is decisive for the response to checkpoint inhibition. And you can actually more or less nail it down to doing a simple immunohistochemistry for CD8, which is available for everybody. And if you analyze that, you can delineate patients who are more or less likely to respond to checkpoint inhibition. Previous work we have done together with Eli Piekarski from Hadassah University or with Lars Sender from Tübingen University has shown that patients who have an amplification of the VEGF-A receptor, which is about 9 to 10% of the HCC patients, are more likely to respond to sorafenib, while those patients that actually have activation of MAP kinase 14 actually show resistance to sorafenib. And this is work from René Bernard's laboratory, where they have shown that the response to lenvatinib, another dirty kinase we're using in HCC treatment, is depending on the FGFR activation on the FGFR signaling pathway. It blocks the FGFR. The resistance mechanism is immediately activating the EGFR receptor signaling path bypass by that, and therefore they have set up a clinical trial where they co-inhibit EGFR and use lenvatinib with the hope then to efficiently stop progression of these tumors. So they are all examples where we could do much better by doing actually molecular analysis of the tumors in shaping the tumor therapy. This is still a lot of work, and we have to work on the clinician. It is now progressing. In our center, for example, basically all HCCs are now biopsied, and we're using these tools to guide the therapy in molecular tumor boards, but it is still a long way to really roll it out to the community. So what we've learned is neglecting liver biopsy was a severe mistake, and we have to work our way back. It led to a lot of lost phase 3 trials. It's probably 10 to 12 of these phase 3 trials which could not be saved because they did not do biopsy. And that was probably a waste of more than 20 million euro, and it led to inadequate guidelines and many more. And now it is reaffirmed because our clinicians don't want to miss intrahepatic cholangiocarcinoma. So the lesson learned is pathologists have to get involved and have to teach the clinician about the right way to diagnose HCC. So my next point is how can we do it better? And we did it better in another entity, which is intrahepatic cholangiocarcinoma. If you look at the epidemiology, you see it's a mess. So it doesn't make any sense. There are different areas where you have high frequency of intrahepatic cholangiocarcinoma and cholangiocarcinoma, and our typing depends on anatomy, not on biology, because the only treatment was surgery, and this treatment was depending on the anatomic region, but it does not reflect the biology. It was the surgeons who learned it actually at the first, and as you can see here, they recognized that cholangiocarcinoma has two patterns. One is the primary nodule forming, the other one is the periductal infiltrating type, like you know it from pancreatic cancer or distal type cholangiocarcinoma, and that they behave differently, and of course their prognosis is also different. It was the group of Yo Zhen from King's College and others who have shown that this actually matches to the histomorphology. So we have a small duct subtype so far, which is more cell-rich, doesn't produce PAS, has still a stroma but content which is significant but less than the large duct type, which is morphologically like the typical ductal type pancreatic cancer with this hazardously spread different glands in an abundant stroma, mucin-producing extracellular PAS positive. So you can make this distinction by morphology, and you can use also immunohistochemistry or molecular alterations. The small duct type is positive for CRP, and it is also positive for albumin in situ hybridization. In contrast to the large duct type, which does typically not express CRP, is not positive for albumin in situ hybridization, and is also positive for S100P. Oops. We can also use these findings to use, of course, digital pathology and AI to support it. The result is pretty much the same as we can see with experienced pathologists, so we can reproduce the morphological pattern. We can use it to distinguish it, as we have shown, of course, from metastases, which is also be done by immunohistochemistry and morphology, and we can use it to actually distinguish the two different subtypes of intrahepatic cholangiocarcinoma. And that matters, as you can see, on prognosis, survival probability, and so on. So it is very important to distinguish it. I can skip that. And we have other means to distinguish them. It's not only morphology, immunohistochemistry. It is also the way these tumors develop. We can actually see that the known premalignant lesions like biliary intraepithelial neoplasia and the mass-forming lesions like MCN, IPNB, and even adenofibroma are all premalignant lesions of the large duct type. They are not premalignant lesions of the small duct type, which also makes a clear distinction in the carcinogenic pathway. And we have looked at the molecular alterations, and there have been popping out specific groups which also relate to the morphology, like the group of IDH1 positivity, which was also found by Yoon Park in her analysis, which also shows that the molecular makeup of these two different subtypes is vastly different. The large type is more this KRAS depending carcinogenesis, as we know from pancreatic cancer, and the alterations in the small duct type are different. IDH1, FGFR, 2 translocations, BAP1, BRAF mutations, and interestingly, these alterations offer actually a lot of perspective for molecular testing in terms of targeted treatment. And finally, the epidemiology is different. The epidemiology and the etiology for the small duct type is the same like for HCC, while the predisposing diseases for the large duct type are flukes, worms, clonorchius, ophistoschius, like you know in Southeast Asia, primary sclerosing cholangitis, and calculi concrements. And this is the explanation for what I've shown you on the first slide, the epidemiology. And finally, we got it in the blue books. In the new edition of the blue books, these will not be subtypes. This will be two totally different entities. And that changes totally the ballpark. That will change the story for transplantation, selection for targeted therapy. Probably many of the clinical and trials have to be redone, and that this is true and that this is necessary, we could show in a study we have done on cholangiocarcinoma in PSC. And PSC leads to cholangiocarcinoma or biliary tract cancer intrahepatically, perihilar, distal, and in the gallbladder. And all these molecular alterations are the same. So it causes the same type and pattern of alterations. And intrahepatically, it is only large duct type. So that's a very clear message and a very clear pattern. And just as a sidetrack, we have now learned that the same specific rare subtypes seem to occur in small duct intrahepatic cholangiocarcinoma. Just recently, the solid tubulocystic subtype of small duct has been described. Inhibin positive, and this tumor always contains the nipple NIC1 translocation. So a perfect match of molecular alteration and this peculiar histology, as you see here, which resembles a little bit thyroid carcinoma. And we have now a rising list of sub-entities where we have starting to sort out matching molecular changes and also respective morphology. So the lessons learned, intrahepatic cholangiocarcinoma is now the perfect example of morphomolecular tumor definition and is now a front runner of targeted therapy, is a front runner of molecular medicine. And these alterations, these changes also in the recognition of the two sub-entities will change totally the way how we look at intrahepatic cholangiocarcinoma and how we will treat it. And what we have to learn also for TNM and other things is we have to look if, for example, our TNM classification also matches biology. This is some lessons we have to learn for the future. Just my last point, just a few 2 or 3 minutes, is how that matters on targeted therapy and treatment. As I've told you, we have a lot of alterations which are actually targetable, about 70 to 80%, as we see in our molecular tumor boards. And this has led, as you see, to different approvals. We have now a couple of approvals we are test in the regular way: FGFR translocation, NTRK, IDH1 and 2 mutations, and even HER2 for the more distal type of cholangiocarcinoma. And this is really, really challenging because NTRK translocations, which are rare, are attributing 3 different NTRK genes and different types of fusions. So you need assays that specifically attribute that. FGFR alterations, which are FGFR2 translocations, are highly specific, as you can see here, for cholangiocarcinoma. If you have a carcinoma of unknown primary in the liver and you find an FGFR translocation in your molecular tumor board, you can call it small duct intrahepatic cholangiocarcinoma. And this offers the way for treatment to FGFR2 inhibitors. And the interesting thing is, in this translocation, it's not a typical translocation as we see it in the other entities. It is very promiscuous. We know now more than 200 partners, and it's only depending on the fact that there is a translocation. This leads to activation of the receptor, not overexpression. So we cannot use immunohistochemistry. We need assays where we can actually delineate all these translocations independent of their vast differences in translocation partners. So we can use FISH a little bit in what we call a peripheral approach, but the better thing is to use broad-based panel testing, NGS, in order to find these changes. IDH mutation have turned to be out positive predictors for IDH inhibitors. The CLARITE-1 trial has been positive, and therefore there is approval for IDH1 treatment, and about 20% of these tumors, which are more frequently clear cell type intrahepatic cholangiocarcinomas, are amenable to treatment. There's 1.3% of intrahepatic cholangiocarcinoma positive for BRAF V600E, and they are quite well responding to BRAF inhibitor treatment. 1.3% also positive for microsatellite instability. Perfect response to checkpoint inhibition. So we have to test for that. So there is a lot of now also drug targets recommended, for example, by the ESMO, which has been tested, have to be tested in the clinical setting, and there are actually more to come. And they are a challenge to our molecular testing. We have now even to extend that testing to complex markers and to even whole exome sequencing and integration of other technologies. Complex markers of like homologous recombination deficiency or tumor mutation burden to actually delineate in the molecular tumor boards those tumors that are amenable to either PARP inhibition, for example, or to checkpoint inhibitors. And the future may even bring up drug antibody conjugates, which actually have to be tested by immunohistochemistry for the specific target of the antibody we're using to deliver the drug. And in future, as you have learned, we might even have to look at the microenvironment in order to delineate those tumors that are resistant or amenable to immuno-oncology treatment. Computational pathology actually may help us to that, but what we need is a whole food chain of complex technologies, bioinformatics, artificial intelligence to make these technologies amenable, and we have to bring it into the clinical setting. If we don't do that, and if we are not actually simply paid for that, if we do not have it in the regular healthcare system, we actually will have a big problem to further these technologies. I'm again trying to move that. I'm sorry. So
if
this,
you left,
yeah, I just got it. Thank you. This is a look at how a molecular report now looks at our center, where all these different molecular items have to be attributed in order to make an informed decision in the molecular tumor board. So in the future, to drive that as pathologists, we need molecular pathology centers, which not only do these diagnoses, they also work in clinical trials, they use this technology for quality assurance, they develop assays, and they do biomarker research. That is a challenge for our discipline, but that is also a perspective which is quite bright. So my last lesson I just want to transmit to you is we have learned a lot from intrahepatic cholangiocarcinoma for that. It has made us think about morphomolecular typing again and has provided a perfect basis for that. And it is a big driver to push us forwards to high-end molecular pathologies. It will certainly lead to centralization. It will drive an innovation circle. And it will certainly be a challenge to the expertise of the pathologists. And that is what the next generation of pathologists have to do. I guess I stop here. I thank you for your attention. And if there's further questions, I'm more than happy to answer that. Thank you very much.
Thank you, Peter. That was fantastic. Brilliant overview about liver cancers and all of the progress which has been made over the last couple of decades. It's really fantastic. Thank you very much. I'm just having a look in the Q&A. I've got a couple of questions written down, but I can see that Mark Ahrens has one. So he says, thank you very much for the very interesting lecture. Spoke about the possible hereditary influences or causes of HCC. What is the likely mechanism by which metabolic syndromes such as hereditary hemochromatosis, alpha-1 antitrypsin deficiency, or hereditary tyrosinemia type 1 lead to the development of HCC?
That's a very good question, and that attributes to the fact that I had to write for the last WHO chapter the story on hereditary tumor syndromes and the liver. And I said there's nothing to write, actually. All these diseases actually work through the chronic liver disease. So it's probably stochastic mechanism of liver cell turnover, proliferation, and so on. You can see that if you sufficiently treat hereditary tyrosinemia type 1, you more or less abolish the risk of HCC, which is tremendously high if you don't do it. The risk for HCC in genetic hemochromatosis is largely restricted to stage 3, which is cirrhosis. So if you treat hereditary hemochromatosis by bleeding very early and you prevent cirrhosis, you probably will not get HCC. And that is also probably the case for metabolic syndrome. So it's those cases largely, not exclusively those cases that are cirrhotic. So the mechanism also in chronic viral hepatitis with some differences because HBV is integrating and is genotoxic. So that is a difference there. So it directly affects oncogenes and tumor suppressor genes. But for the others, the largely mechanism is the chronic liver disease and the cirrhosis.
Thank you. So there's another question from Owen Kane. What is the current state of knowledge of the pathogenesis of liver lesions in inherited vascular disorders such as Abernethy malformation?
Well, that is a very, very good and a very, very difficult question. There has been publications by Christine Sampu, Valérie Paradis, and so assembling those lesions in vascular disease, as you said, like Abernethy malformation and others. It has turned out that there's a whole bunch of different lesions. Some are called regenerative, FNA-like, others are called adenoma, but we have learned independent of the morphological pattern, there seems to be a risk of malignant transformation. So we always say there's a caveat. So we say it looks like an inflammatory adenoma or it looks like an FNH, but follow it up. We don't really know the course. As this is rare, we do not have good clues about the molecular mechanisms. So it is more or less an ignorance on that. That is depending on the plethora of the lesions we're seeing and the fact that it's quite rare. The only thing is they're more unpredictable than the others, and we have to be careful in saying it's a benign lesion.
Okay, thank you. Another question from Yozen. Thank you very much for the wonderful lecture. And is HCC arising in hepatocellular adenoma always associated with a beta-catenin mutation? Are there any other carcinogenic pathways?
This is also a very good question. I would say that the malignant transformation is largely due to the conventional exon 3 mutations. This is the vast source of those adenomas, if you call it adenoma, that lead to malignant transformation. That is not true for the S45 alteration and not for exon 7 and 8. There has been a report of very few adenomas also malignantly transforming. So there's never an always or never a never in medicine. And there has been reports, Jo knows it, from Mike Torbenson's group on late adenomas with HNF1 alpha deficiency transforming. But it has not been conclusively shown whether they have ever been adenomas or have they been adenomas. And they might have been HCCs actually from the beginning, or should have been termed HCCs, which also show HNF1 alpha deficiency, which you can find in some cases of HCC anyhow. So to my opinion, in these publications, in these clues, it's a lumping together of questionable adenomas, true HCCs, and the question is if they really arise from HNF1 alpha deficient adenomas. But never say never. There might be extremely rare cases where the other adenoma subtypes may transform, like we see in others. But the risk is so negligible that we should not put it forward as a premalignant lesion and should not make the clinicians reject it for the reason of malignancy, rather bleeding risk or something else.
Okay, that's wonderful. So I've got too many questions. I'll probably have to write to ask them, Peter. Probably the one that possibly the most important one is you mentioned at the very end the integration of the clinical symptoms, radiology, AI, and mutational analysis, and that with that then you're able to bring together an integrated report, which looked very impressive on the slide. Is there a possibility of, instead of doing a wide genomic panel for liver cancers, is it possible to come up with a bespoke next generation sequencing panel which would look at both the mutations and the translocations of the vast majority of the tumors? I mean, it could well be that something exists like that already. I'm not sure.
Yeah, I mean, you can do that with whole exome sequencing, whole transcriptome sequencing. You can, what we are doing conventionally is doing together a TSO 500 and TST 170 assay, which grabs both.
Mm-hmm.
If you specifically attribute an HCC, I'm not sure that we will solve all the questions just on the genomic level. I mentioned the drug antibody constellation. I mentioned the CD8 immunohistochemistry for the immunoenvironment. So I think in the future it will be a mix of both, and we have to select it depending on the way the approvals move forward and what we do in the molecular tumor boards. Actually, what we're doing is we're more and more going towards the one-fits-all whole exome sequencing.
Okay.
Maybe exome plus whole transcriptome sequencing,
Mm-hmm.
because it is a big hassle to always adapt the different panels and to switch between the different entities. So in the long run, it's the way it's make the assays cheaper, make it more productive, so have an automated food chain, and then you can use the more extensive things. That is the better one.
Right. Great. I'm afraid we're going to have to leave it there. Thank you very much for your time. It's been fantastic. I'm sure everybody has really appreciated it. Those who don't know, these lectures are recorded, and so there's the option of playing back the lecture and taking it at your own pace. Thank you very much again, Peter.
Thank you. If there are further questions, you're free to transmit it, and I try to answer it. Thank you very much for being with you.
Thank you. Bye then, and thank you. And just to let you know, that we have the last lecture, which will be coming up, and we have it on the screen now, which will be given by Dr. Adam Byron. And he will be speaking about the extracellular matrix and its role in gene regulation. And this will be on the 10th of December, and this the same usual time on between 9 and 10 o'clock. So thank you very much, and I wish you all a pleasant day. Thank you. Goodbye.